Hey everybody, this is Sam Beeger. Sorry, I couldn't be there today. Miss you guys. I'm going to be gone through the weekend, but I'll be back on Monday. Let's see if I can share this screen with you. So here's my presentation on treatment for DVT, short-term and long-term. On the left, we have a picture of a DVT, and the goal of treatment is to restore normal blood flow without creating an embolus, which you can see on the right side. And then the molecule that's on the right is also it's actually warfarin's molecular makeup. So I looked at some therapies from UpToDate, and one included thrombectomy, which is actually a surgical removal of the clot. However, this it's effective at removing the clot, but it's actually not very effective at preventing DVTs from in the future. The scar tissue actually seems like they have equal, if not worse, rate of return of a DVT in the specific area. Another actually very effective treatment is ambulation for prevention. Just like running water doesn't freeze, flowing blood doesn't clot. So your calf muscle, as you can see right here, actually acts as a pump to get the kind of static blood in your veins moving. Compression stockings, the jury is out. From what I found and from what UpToDate said, no real clear findings on that. As we said before, the inferior vena cava filters. This is probably the most extreme measure to prevent like pulmonary embolism or a stroke. And this is really only used in patients who have like a severe problem with anticoagulation, such as like excessive bleeding, hemorrhagic stroke, or recent surgery. So by far, the most effective treatments for DVT are anticoagulants. And here's actually a flow chart that you can see from about the treatment of DVT. Goes through, but as you can see right in the center right here, most roads lead to anticoagulation. There are sometimes where, you know, like specific cases where it's not necessary, or it's actually not, it'll actually harm the patient more to anticoagulate. But most roads lead to anticoagulation. So for initial anticoagulation, heparin is probably the most used medication. It's a short-term anticoagulant. Its biological half-life is only like 1.5 hours. So it actually gets removed from the system very, very quickly. It's given IV because it's too large to be given orally. It can't be absorbed in the gut. The other thing is actually it can be given IM as well its half-life in IM form is much longer. The way it works is it binds to antithrombin 3, which makes it much more effective at inactivating some of the clotting cascades, like thrombin or factor 10. It's extremely fast acting. And it's given initially for DVT, but then most often, except in its IM form, it's replaced by a different I said coagulant, but I meant anticoagulant for long-term treatment. One interesting thing that I thought about heparin was that it's actually used in these lab tubes to prevent coagulation as blood's going to the lab. So the green tops have heparin in them. Let's talk about warfarin or Coumadin. Coumadin's the generic name for warfarin. It's a very common drug because of its low price, and it's very effective. It has a longer half-life. It can be reversed and controlled with vitamin K. In fact, patients who are taking warfarin are often discouraged to eat too much leafy greens. Let's see. It's recommended that patients check in quite a bit when they're on warfarin, and so that way the dosage of the warfarin can be managed because its effectiveness can change based on the patient's diet and a host of other factors. There's an interesting fact. It first came into use actually in 1948 as a rat poison. So basically, the rats would eat it and would essentially bleed out. Yeah. So it worked as it was a toxic dose of an anticoagulant. So they just basically bled out. How does it work though? It works by actually inhibiting the vitamin K epoxy reductase, which is basically how vitamin K returns to its active form. And so we learned actually about this in our lecture on Monday about how vitamin K is a gamma carboxylating agent for a lot of the clotting factors, such as factor 2, factor 7, factor 9, factor 10, protein C and S. So basically, it prevents vitamin K from returning to its active form. So the question for me was, why warfarin? Can aspirin be effective? So I actually found a great article in the New England Journal of Medicine about this. So essentially, what they did was they took 411 patients and gave them aspirin, and 411 patients and gave them a placebo, and all of these patients had a DVT and had completed an initial anticoagulant therapy anywhere from 6 weeks to 24 months. And the primary outcome that they measured was the recurrence of a venous thromboembolism. Essentially, what they found out was that aspirin did have a small effect, but it wasn't statistically significant in reducing the rate of venous thromboembolism. But there was a significant reduction in the rate of major vascular events, such as myocardial infarction, stroke, and cardiovascular death. So it reduced all those significantly by 34%. So even though there was a small benefit in the previous study about like seeing a recurrence of a thromboembolism, it wasn't statistically significant. And fact is, or when we looked up on UpToDate, it looks like there are a lot of other anticoagulants that have a much better effectiveness at preventing further venous thromboembolisms. So essentially, from what UpToDate said, the initial treatment, the first 10 days, there's immediate anticoagulation, starting with heparin or another immediately acting anticoagulant, and then progressing from heparin into a different longer acting anticoagulant. If you start on warfarin, then slowly wean off the heparin once the vitamin K is used, and it usually takes about 1 to 2 days. So, and for most patients with the first episode of DVT, they recommend anticoagulant treatment for 3 months minimum, going up to around like 2 years. But actually, look for even after that, long-term treatment could be indefinite, and that's there's a number of factors like age, basically, and a bunch of risk factors, patient choice. So it's usually this. There are a number of factors that go into it, and it's usually decided by the patient and doctor together. So say there is a patient who wants to be on a long-term anticoagulant, or is going to be prescribed a long-term anticoagulant. I was curious which ones would be the best, and so up to date, recommended for patients who are hemodynamically stable, non-pregnant, or don't have renal insufficiency or active cancer. They actually recommended factor 10A inhibitors. Probably the most common one is Xarelto, or oral direct thrombin inhibitors, such as Pradaxa. These are actually, yeah, they're much easier for the patient, because warfarin requires multiple office visits for INR monitoring, and actually has higher bleeding risk when compared to the other inhibitors. One thing that's interesting though is Xarelto and Pradaxa don't have very good antidotes for if you say this patient does have a bleed, for how to stop the bleeding. Whereas with warfarin, you can just give vitamin K, and it's much more readily available. So it's kind of, there's a trade-off, because there's a higher risk of bleeding with warfarin, but also it's easier to control. So basically, it sounds like with warfarin, if you have a patient who is a fall risk, where or the patient needs frequent interventions, it might be better to start them on warfarin, just because it's so easily reversed. I actually remember in the trauma unit where I would work, there was one trauma surgeon who was just really angry because one of the patients, he didn't know what type of anticoagulant it was on. He was just lamenting about how he preferred warfarin because at least he could reverse it. Also, for patients with poor compliance, warfarin is something to consider. So that's it. Since I'm gone, I'm gonna assume that that you guys thought the presentation was clear and have no questions. So no, I'm just joking. Feel free to email me any questions, and I'll get back to you guys on Monday. Thanks a lot.